That leads us into the lungs. When we just talk about the lungs? Yes, we were. This is kind of the gross anatomy of the lungs. Okay. Still in the lower respiratory tract. We'll get through this and then we'll take a little break. There are the lungs in all their magnificent glory. They are located within the thoracic cavity. Pretty obvious. They're on either side of the mediastinum. Mediastinum is the blue shaded area there. What's the mediastinum? It's where the heart sits, right? We have a number of surfaces, guys. I mean, I don't really ask them. There's a costal surface. What do you think the costal surface of the lungs comes in close contact with?
The diaphragm.
Nope. Costal.
Intercostal region, like between the ribs.
Comes in contact with the ribs. Hopefully it doesn't get in between them. But it comes in contact with the ribs. There you go. Diaphragmatic surface. Imelda, where do you think that comes in contact with?
What?
Diaphragmatic surface. What do you think that comes in contact with?
The ribs.
The diaphragm.
Okay.
Okay, look at the name. There's your diaphragm right there.
Yeah.
Okay, diaphragmatic surface of the lungs comes in contact with the diaphragm. Costal surface here. This is the costal surface of the lungs. Hell, maybe I should ask these questions on the exam. The inside here comes in contact with the heart. And they're just going to give it a general name, the mediastinal surface. So, I mean, there's a ton of anatomy here. I guess maybe I should probably reassess how I ask questions. We have an apex and we have a base. Apex of the heart points up or down?
Down.
Down, good. Okay, and there's the apex of the heart right there. For the lungs, that is reversed. Okay. The base was up high for the heart. Apex was down low. It's the exact opposite here. Base is on top of the diaphragm. So that diaphragmatic surface is basically the base of the lungs. The apex of the lungs is right here at the top, which doesn't look too bad. But when you put the anatomy, the bony anatomy around it, holy smokes, look at that thing. There it is, poking up. It is one of the most common things that for all of you who are going to be radiologists or rad techs, this apex is one of the most common places for cancers and other nasty crap to go up and hide. It's referred to as the cupola as well, but just call it the apex. It's kind of the name that is primarily used now. That apex, Pancoast tumors and some other various different types of tumors love to go up there. So if you collimate out, which can happen sometimes as you try to filter out the excessive amount of x-rays that you're exposing the patient to, if you collimate out at too low, you can not get the apex of the lung involved. And if you're taking an x-ray of the chest and you don't get the apex of the lungs, you can't get paid. It's a faulty study. Okay, so got to make sure you get that apex of the lung. It's a pretty important piece of anatomy there. And as you can see, it pokes right above those first ribs, just right behind the clavicle. Okay, it's even kind of above the clavicle a little bit, depending upon how you get the tube angle when you take an x-ray. Here's a nice little picture here that shows you the 3 lobes of the right lung, the 2 lobes of the left lung. Seems pretty easy. The right lung three lobes: superior, middle, and inferior. And over here on the left, we just have a superior and an inferior. We have fissures as well, and fissures and lobes, that's primarily what I ask. I believe that's all I ask about them all. I don't ask about surfaces and notches and all that whatnot on the lab exam, so I don't bring that over into the lecture either. But we have a oblique fissure, runs at an oblique angle. And we have an oblique fissure right there. In that right lung, though, we have an additional one. That's the horizontal. Okay. The horizontal fissure helps to separate the superior lobe from the middle lobe. Oblique really does the inferior from the middle. A little bit of the inferior and the superior, but really just the inferior and the middle lobe. We have a cardiac notch. Again, that's where the heart, the heart is residing towards this direction here. So you have a little notch for it. Okay, I don't really care. I don't ask about it. There's the hilum on the backside. There's the hilum, that opening where everything comes in and out, the main bronchus, pulmonary veins, pulmonary arteries, nerves, lymphatics, all that fabulous stuff goes in and out right through there. On the backside, there's some impressions. There's an aortic impression. There's a cardiac impression. Again, it's just the anatomy that kind of runs along that area, and I'm not going to ask about it on the exam. Lobes, fissures, that's what I like to ask. Here's a nice little picture that shows all the little bronchopulmonary segments. I'm not going to ask, but there's 10 segments on the right, and there are 8 in the left. So even though there is a little bit of difference between the lungs there, it's not huge significant difference, especially if you are normal. If you're somebody with a emphysema or any of the other conditions that can destroy the alveoli, then that small little change in numbers there can be very significant. Getting asbestos in the lungs. Okay. Anything that reduces the number of alveoli, then that slight little difference becomes magnified. But it's all normal, 10 and 8. I don't ask that number. I ask usually about number of lobar bronchi. That's generally what I ask. Primary bronchi are pretty easy. There's only 2 of them. This is a fabulous picture. There's a normal lung. Holy Christ, look at that thing. There's somebody who's a nasty smoker. Look at the difference between the amount of inflation that can occur in these things. It's disturbing. Look at that thing. Disease. Ugh. Wow. Isn't that just crazy? Look at that again. Wow. That is a huge difference. When you destroy those alveoli, you destroy capillaries. Yes, but what else are you getting rid of? Elasticity, elastic tissue gets destroyed as well. The ability for those lungs to expand is drastically diminished when you have destruction of these structures. Okay. And this is just a great picture show. I don't know. I wouldn't ask you what are the 1,500 different things that I have here that occur with smoking and some potential causes. Can smoking affect elasticity of lungs? Yes. Can smoking, if I can't inflate my lungs as much, does it make sense that I'm not going to be able to get in as much oxygen? I hope so. If I don't have as much oxygen in, what am I going to have to do? Well, I'm going to have to increase my rate of breathing, right? I'm going to have to try to force myself to breathe deeper. So I'm going to have some forced inhalation and some forced exhalation probably as well. So although I'm not going to ask anything specifically off this slide in terms of increased chance of death, I may ask a question based on a situation. Okay. Smoking reduces the ability for the lungs to expand. If the lungs cannot expand because of loss of elastic tissue, I can't get as much oxygen in. Just as importantly, I'm going to be diminished on the amount of CO2 I can get out. So if I want to increase my ability to do stuff where I need more oxygen, it's going to be very difficult to do. And that's all I'd probably ask based on that situation. I just love the picture there, looking at those lungs and how much. It's just crazy.
I have a question. If you stop smoking, can you regain some of that elasticity and all of that in your lungs?
Shockingly, shockingly, yes. It's amazing. If you are a casual smoker and you stop smoking within, I think, like 3 weeks, you are damn near back to what you were prior to. The lungs are pretty resilient in that regard. Can it get back to what it was, 100% where you were before? Yes, it just takes a little bit more time. If you're somebody who smokes for 10 plus years, you can still get back to damn near normal within a month or two's time. Depending upon what you smoked, getting back to 100% may be a little bit more difficult. Also, it's more of, at least they're finding now because of those, whatever those things are. I don't know the name. I don't smoke. Using the e-cigarette, that's it. It superheats it, and which is greater. It's a greater amount of heat that you're exposing the lungs to than if you just did it with your thing lit and smoke. So that changes, and I have not seen any studies in regards necessarily long-term studies to that. I've seen some short-term where you see some massive damage and an inability for the lungs to regenerate in the short term. And plus a lot of those are affecting children as well. So I don't know if doing the e-cigarette with superheating that stuff, as well as some of the other chemicals that are in it, because it's a hell of a lot more chemicals to maintain that cartridge for an extended period of time. So you're exposing the lungs and the tissues in the lungs to a multitude of other different chemicals as well. So I haven't seen any long-term studies with that, but if you're a normal smoker, it can get back to normal pretty dang quick, which is shocking. This obviously here, I can't remember. Somebody sent it to me and I put it in here. I can't remember where they got it from, but this is a chronic smoker, obviously. So did he live? Probably not, right? So, but yeah, it's a diseased lung is very different from a robust, healthy lung. So, but if you're a smoker, stop. You'll smell better about yourself. See what I did there? I know, I'm a dick. Okay. Blood supply to the lung. All right, guy. I don't know if I really want to get into it. The lungs need to be perfused with blood. There are two types of circulations that occur here within the lung. There is a pulmonary circulation that's going to be involved with exchange of gases. Okay. And then there's going to be a bronchial circulation, and this is going to be the part that transports oxygen to the tissues of the lungs. So it seems pretty obvious to me, the difference between the two. Maybe not so much, I guess. I don't know. Maybe I am taking a leap of faith there, but Pulmonary circulation, this is the one where we have deoxygenated blood coming from the lungs, or I'm sorry, from the heart, right, to the lungs. This tissue also needs oxygen as well, and that's what bronchial circulation is. So the lungs need blood. Gas exchange here isn't enough to supply all of this tissue with enough oxygen to do stuff. So there are two types of circulation there. I don't really know what else to say about it than that. Lymphatic drainage. This is an avenue from the outside, right? If I breathe, it's going up my nose. I mean, yes, I got lymphatic tissue up there, right? Tonsils. But it may not see it. Can stuff get down into the lungs and potentially cause an infection? Sure. So, I mean, obviously I'm going to have some lymphatic tissue there as well. Yes. I mean, you know, it helps to collect any foreign stuff that gets in, remove any excess fluid. There is a significant amount of fluid that gets produced in the lungs. So it helps to get rid of excess. So, I mean, but those are functions of the lymphatic system. So I don't feel like that's a huge stretch. Is there lymph nodes there? Yes. I mean, it's open to the outside world, right? Through my nose, through my mouth. So would it stand to reason that there would be some extensive lymphatic type tissue there, lymph nodes within the bronchiomediastinal region there? Yeah, and we already looked at that. So I don't really feel there's a huge number of questions coming off of this slide, or this one, to be honest. The last major thing that we have here, well, I don't know if it's the last major thing. Yeah, it's the last major thing. Associated with anatomy is the pleura. Everything is wrapped in connective tissue, right? We looked at it, the heart. We had a visceral and a parietal membrane around the heart. Visceral pericardium, parietal pericardium, right? We have a pleural membrane around the lungs as well. We're going to have it around every single structure from here on out for the most part, except for a handful. That's it. Everything else is going to be wrapped in this membranous tissue. What it's composed of, I don't really care. Visceral pleura and parietal pleura, those are our two sides of our membrane here that surround the lung. We have the visceral pleura, visceral, so that means the organ. So this is going to be the part that's adhering to the surface of the organ, the lungs. And we have the parietal pleura, and the parietal pleura lines the cavity in which the lungs reside. Okay. Helps to kind of hold the lung together, keeps it anchored in space. Most importantly, though, it's going to help with breathing. What? Yeah, that tiny little membrane is going to help with breathing. How? Well, because of water. So here is my pleural membrane. There is the pleural cavity, and this is the parietal pleura right here. This is the costal surface right here. Okay. We have, and then it folds around on itself, and there's the visceral pleura. Okay, just like we had, same thing with the heart, same setup here. And you can see we have a potential space between those two. And it's called the pleural cavity. Is it empty? Of course not. Nothing's ever empty, right? We have a serous fluid that is filling that tiny little space. And when I mean tiny, guys, I mean this is exaggerated for you to see. It is very tall, very thin space. I can't even get my thing to really get it any closer than that. I'm trying to get as close as I can. There we go. Look at that, getting better. It's a very small space. Okay, that's why they refer to it as a potential space. Because as soon as you take a breath in, well, now that space is gone. So that's why we say it's a potential. Okay. What does fluid do? Fluid do what always fluid do, and fluid do lubrication. Okay. It helps to make breathing easier. That's what it does. It's also watery. And what did I say earlier about two membranes that are wet? They stick together. So as you take a breath in, keep going. Okay, as you breathe in, that pleural cavity becomes, remember, that potential space. Okay. This helps to pull this thing with it. And I'm sorry. This helps the thoracic wall pull the lung with it because they're watery. Okay. As the lungs keep expanding here, okay, you feel it. You feel that little stretch that occurs right through those lungs there. Take a deep breath and keep going with it. Go as far as you can with it. Okay, you can feel that pull. Okay, you can feel that stretch that occurs there. That stretch that is occurring within the lung to inflate those suckers even greater is enhanced by this serous fluid that fills this potential tiny little space. If you get some kind of infection in your lungs and it's painful to breathe, that is pleurisy. If you just, and it causes friction between those two sides, okay, between the horizon, good God, between the visceral pleura and the parietal pleura. And if this is inflamed, there's even less room for fluid. So you'll feel it. Very high grit sandpaper, okay? If you put your hands on the patient's back, you'll feel it when they breathe. Hell, just have them say 99 because breathing will be really painful. Just have them say 99 and you'll feel it. And you'll feel all that rubbing in there. It'll be really painful for them to breathe. For the person that sent me that thing, I'll reply to you here in a little bit. How do the lungs remain inflated? Well, we're going to have a high number of pressures, okay? And, this is what happens when the atmosphere and the pressure within the lungs or within the cavity where the lungs sit become equal. It collapses, all right? And, atelectasis, pneumothorax, depending upon the wound type. That is what happens when the atmospheric pressure equals the pressure inside the chest. All right. We have intrapleural pressure. This is very low. And the elastic tissue that we find within the lungs allows it to expand. And again, that watery fluid helps to kind of cling to that outside surface and expand those lungs even more. Intrapulmonary pressure, and that's just pressure within the alveoli, okay? And these are terms that we'll see again, is greater. So when you, yep, my lungs didn't collapse, okay? The pressure inside the alveoli is greater than what's in the space. And it's that little bit of extra pressure that is existing, and it's not a whole hell of a lot, That little bit of difference is what prevents those lungs from collapsing. Okay. So we're going to have a number of pressures associated with breathing here to control the breathing process. And these are just two of them. Okay. The pressure outside of the lungs and the pressure within the lungs. Okay. Intrapleural is very low. Intrapulmonary within the lungs is really high. And that's going to help to maintain the openness of these lungs. Okay. So if I get those alveoli to collapse, the pressures are going to be equal. And that's not a good situation. Very painful to breathe. Very painful to breathe there. Okay. You could see some causes for it. Crazy. All you got to do is insert a tube to remove the air. Insert that tube into the intrapleural space there to remove the air. And then you can reinflate the lung. That doesn't sound like a fun time. This question seems really weird, but I may have a picture. Sometimes I do, sometimes I don't for some of these. Sometimes I ask a question of follow the rabbit. So if I said follow an air molecule from right outside your nose to the place of gas exchange, could you follow the rabbit down? Nasal vestibule, nasal cavity, nasopharynx, oropharynx, laryngopharynx, larynx, trachea, primary bronchi, lobar bronchi, segmental bronchi, bronchioles, alveolus. Could you do that? Hell yeah, you can.